Mr. Walgan, you may call your next witness.
Thank you, Your Honor. People would call Dr. Stephen Shafer to the stand.
Doctor, please remain standing. Raise your right hand. Do you solemnly state that the testimony you may give in the cause now pending before this court shall be the truth, the whole truth, and nothing but the truth, so help you God?
I do.
You may be seated. Please state your name for the record. Spell your first and last names.
Stephen Lewis Shafer, Stephen, S-T-E-V-E-N, Shafer, S-H-A-F-E-R.
Dr. Shafer, good morning. Let me provide you with some instructions. First of all, we'll provide you with a cup for the water. We don't like to advertise. So you'll be able to pour the water into the cup. No, that's all right. You can just put it down to the side. This way, people's view is not distracted. Now to the real important directions. Please sit back and relax. Please speak loudly so we can hear you. You can face front and the jurors. If you're called upon to provide a yes or no answer, please answer yes or no rather than the slang which can be tricky. And lastly, please wait until you hear an entire question before you answer it. In our daily lives, many of us are used to talking over each other. It's routine. But in a courtroom, it's important to have the full question asked and then respond. Is that all okay?
Very clear, thank you.
Thank you. Direct, please, by the people. Mr. Walgan.
Thank you, Your Honor. Good morning, Doctor.
Good morning.
What do you do for a living?
I'm an anesthesiologist.
And what is an anesthesiologist?
An anesthesiologist is a physician, graduated from medical school, and then spent 3 years in training to learn the specialized skills of anesthesia. An anesthesiologist is responsible for, the classic view is that we anesthetize patients for surgery. But what we actually do is really perioperative medicine. We assess patients prior to surgery. During surgery, we don't not just keep them asleep, but we're actually responsible for keeping them alive. We're responsible for their vital signs, responsible for the circulation and everything. After surgery, we are often responsible for them when they go to the critical care unit. So critical care is one of the subdisciplines of anesthesia. And because we're very much involved in pain management as part of our practice, many anesthesiologists are focused on pain management as well.
We're going to try to speak just a little bit slower.
Sorry.
That's all right. All of us. Mr. Waller?
Thank you. And in regard to you being a medical doctor and specifically an anesthesiologist, can you tell us a little bit about your current academic titles and positions that you hold?
Yes. I'm a professor of anesthesiology at Columbia University. I'm an adjunct professor of anesthesia at Stanford University. And I am an adjunct professor of bioengineering and therapeutic sciences at the University of California, San Francisco, in the School of Pharmacy.
And as far as being a professor of anesthesiology at Columbia University, how long have you had that position?
I started in 2007.
And in regard to being a professor of anesthesia at Stanford University in California, how long have you had that position?
I joined the Stanford faculty in 1987 and remained on faculty as an assistant professor, then as an associate professor, and I became a tenured professor at Stanford. I believe the year was 2000.
And as far as being an adjunct professor of bioengineering and therapeutic sciences at University of California, San Francisco, what is the class that you teach there?
There is a class, a graduate level class in what's called pharmacometrics, which is the science that relates how you give a drug to the concentrations and then what happens in the patient. And I teach in that class, which is the nature of that appointment.
The science, you indicated the science of when you give a drug, and what did you follow that up with?
I'll work on speaking slowly. Pharmacometrics is a branch of science that deals with mathematical models to relate the dose of drug to the concentration of drug in the body, and then to relate the concentration of drug in the body to what the drug actually does. It's been a discipline that has grown for about the last 50 years and has grown somewhat explosively in the last 20 years with advent of modern digital computing power.
And this science, pharmacometrics, that helps determine dosages and what dose is effective and the et cetera?
Absolutely. Pharmacometrics is one of the core competencies of every pharmaceutical company because they're expected to put together mathematical models that explain how when you get a certain dose of a drug, how your body responds in a certain way. And companies have to understand this in order to develop drugs at the right dose and then bring them to the market at a dose that's effective without also being toxic. So it's a core competency of every pharmaceutical company. It is a core competency of the Food and Drug Administration. I'm sorry. Core competency of every pharmaceutical company. And it's also a core competency of the Food and Drug Administration. And it's incorporated into every label for every drug that the Food and Drug Administration comes forward with.
And those labels then can help doctors, serve as guidelines for doctors to now know what the appropriate dosage is and things of that nature.
That's absolutely the point. That's absolutely correct. The purpose of the label is to guide the physician on how to use the drug safely and minimize toxicity. And pharmacometrics is the science that provides the numbers, the quantitative numbers that are used.
And in the end, when you say to minimize toxicity, what you're really saying is to minimize injury to the patient.
Absolutely.
Now, the Columbia University, Stanford University, and the University of California, San Francisco, is it fair to say those are among the top 3 medical schools in the country?
They're up there on most such lists, yes.
Okay, and you hold professorships at each of those 3?
Correct.
Now, you also are an editor-in-chief of a prominent anesthesia journal, is that correct?
Correct.
And what journal is that?
The journal is called Anesthesia and Analgesia, and it's the largest medical journal in the field of anesthesiology and perioperative medicine.
And as editor-in-chief, then, what do you do? What are your responsibilities as far as operating this anesthesia journal?
Well, I see every manuscript that is sent to the journal, and we get over 2,000 submissions every year. So I see 2,000 manuscripts come through. I personally screen the manuscripts for both merit and for integrity. For example, has any sign of plagiarism or any concerns about fraud. I then either handle the manuscripts myself, and I handle approximately a quarter of all submissions to the journal personally, or I assign them to a member of the editorial board. And we have an editorial board of 70 senior scientists and clinicians who handle manuscripts for the journal. Then they make decisions, the papers come back to me, and I review the decisions, and then we send the decisions to authors. Just by way of example, while I was waiting outside today, I handled 27 manuscripts. It's a treadmill that just goes on and on.
And when you say, excuse me, when you say manuscripts, what are we talking about? What is a manuscript?
Most manuscripts are research studies where someone has performed some sort of research relevant to anesthesiology or perioperative medicine And they would like to see that paper, which used usually data, patient subjects, or maybe cell cultures, or very basic science, but they would like to see that paper appear in anesthesia and analgesia. We also have things like case reports, just odd things that happen that people think might be interesting.
Now, as editor-in-chief of this journal, you have an editorial board, you said, of about 70?
Correct.
Okay. And does Dr. Paul White, one of the defense experts in this case, serve on that editorial board?
Absolutely. Paul is currently if I may add,
Sure.
Paul is currently the section editor for the multimedia, book, and meeting reports, and is the former section editor for the section on ambulatory anesthesia as well.
And in your task as editor-in-chief and the review process that goes through these academic submissions, I assume a certain number are rejected as not meeting the standards of the Anesthesia and Analgesia Journal?
I actually run metrics every quarter, and our most recent statistics are that our acceptance rate for original research manuscripts is about 21%. So nearly 4 out of 5 papers get rejected.